Hello, everyone. My name is Min-Seok Soo, and I think some of you may have seen me from the summer workshop TAIN. And so today I would like to welcome you all to the distinguished lecture series by Professor Edmund Kim. Before starting the lecture, I would like to briefly remind you some introduction. If you have any kind of questions for this lecture in between the lecture, you can just write down your questions at the chat, and then we will have a discussion time at the end of the lecture. So I invite all of you to actively enjoy the lecture and join for the interactive communication with us. So today, I would like to introduce Professor Edmund Kim. So Dr. Edmund Kim is one of the most accomplished doctors in the field of cancer research. And he has served as a tenured professor at the world's leading MD Anderson Cancer Center for 32 years. And today, Dr. Edmund Kim will share us up-to-date knowledge of imaging in the prostate cancer. Please welcome Professor Edmund Kim.
김동민 씨 마이크가 꺼져 있어요.
Can you hear me well now?
Yes, Professor.
Oh, sorry. Okay. Thank you very much for a nice introduction by Professor So. And I'm very happy, privileged to give this lecture to my old and new friends in your countries. And I appreciate Professor Tong-Soo Lee to organize this special lecture series. And we are hoping that you are learning something from me and from others here in Seoul, and try to make your life maybe more useful and enjoyable. I know you have a difficult time with the coronavirus, just like everybody else in the world. Whenever I face this kind of unexpected problems, I always compare with my young days during the Korean War. As you can imagine, you know, everybody was suffered from all unexpected you know, fightings and hunger, etc. I'm sure you all know that the life is totally unpredictable or sometimes unfair. But if you go through, overcome certain problems, you'll be stronger, you'll be probably better in many things. So try to just be patient, try to work, whatever you can do at best, and then you will have a better time soon. When the Professor Tong-Soo Lee offered me this special lecture series, and he decided to start with the common clinical problems. Since I have been interested in cancer and I was in the cancer research for many years, I start with common cancers. And then later, maybe I will talk about more research aspects that is related to immunology, metabolism, and genetics. the reason I do is that the nuclear medicine is basically research-oriented medicine. So whatever you do, you have to keep in mind thinking and maybe doing some kind of either clinical or basic research. Try to make any diagnostic method better or treatment better than what we have at this time. And also, we are in the service department. We are dealing with all clinical departments. So whatever you learn, new things, you must talk to your clinical friends so that they can think about this new ideas and then possibly utilize your ideas in their clinical practice. So I'm trying to talk to you today about the commonest problem, at least in United States, that is prostate cancer, and how we offer as an imaging sort of practitioners or researchers in the management of cancer in clinical environment. So doesn't move. My slide doesn't move. Oh, okay. Now, this is a little bit old slide, but you can see that prostate cancer is the most commonest cancer of the male. You can see here, and much more than other other cancers, particularly the thyroid, these cancers. But as you notice that the peak instance was around 1995 at the time of utilizing a routine blood test for PSA. That's a blood test, and it pick up and then slowly down, but lately it stabilized, maybe even more slightly increasing. And the thyroid cancer is much lower in instance, but it's continuously rising. And this can be also due to similar sort of routine studies of a thyroid hormone test and then ultrasound examination. But anyway, still very common problem. In the female, breast cancer is a rising and most common problem in cancer. So both prostate and breast cancers are hormonal cancers. And therefore, it's all in males, it's a male hormone, androgen testosterone. In the female is a estrogen hormone, influencing cancer development and also in the management. Okay, the last year statistics in the United States showed around 170,000 new cases, and about maybe six, maybe 30,000 prostate cancer patient was died. And this is important, 35 patients developed recurrence. This is either biochemical recurrence or certain clinical recurrence. In the old statistics, about 50% of the patient who had the surgery, they developed recurrence. So that's the major clinical problems. And the, okay. Now this is also showed that usually prostate cancer occurs in older patients, usually after age of 50. But recently there are many also middle-age, 40, younger patient also develops this kind of cancers. The same thing in the breast cancer also incidence is also very unusually occurs in the younger patient, younger, like 30, even 20s. And they must be all related to hormonal changes. And the, you might have heard that the many normal sort of asymptomatic patients also were found to have prostate cancer at autopsy. They statistics show about 30% men over age of 50 also show this kind of silent prostate cancer. And so that's why in the management, there's always a lot of debate whether we should approach some aggressive treatment or just wait and see. So that has to be all related to aging, age. Aging is the most important. And the prostate cancer occurs in peripheral joint. I will show you anatomy of prostate in 70%. And the transitional joint, usually where anterior upper is about 20%. Central joint is 10%. So these are 30% prostate cancer may have a very difficult to diagnose, because in this old age, we normally see hypertrophic, hyperplastic changes in the central and transitional joint. So there's always a nodular appearance on the any imaging in this central or transitional joint that could be related to just a benign hypertrophy or hyperplasia. And so you have to keep in mind, any imaging will miss small tumor in this location. So on the peripheral joint, it's rather easier to diagnose by current imaging technique. However, when we are getting old, peripheral joint becomes less in amount. It's thinner. So that's another problem and a routine diagnosis. Okay, now we still don't know exactly why certain people develop cancers. Obviously, a lot of genetics, environmental, and many other nutritional, many factors involved. But basically, there is an androgen receptor. This has to be activated by certain testosterone male hormone and certain corticosteroid, some other drug or medications, and then certain growth factor. There's a lot of growth factors in our bodies normally, but somehow this is accelerated and then go through certain genetic pathway, and then finally stimulating androgen receptor, and that will go inside the nucleus, make a cellular proliferation, and then PSA level is elevating or rising, and then this all another mitochondria, which is a sort of a source of our energy, and there's a certain gene like a BCL2 affecting, and that will also make things. So what's the androgen? Androgen is a sex hormone. a sex steroid. So a lot of sports guys take androgen injection to gain muscles or things, or sexual things. And this male hormone is basically needed for reproductive and sexual function. And well, I will show you. Just like any other hormonal system, there is always a sort of a feedback systems. There is lutein hormone in pituitary. The hypothalamus has a lutein releasing hormone. These and then testosterone in testicle, all this feedback system. And then there is a small portion of adrenal gland producing androgens. So these are all sort of in feedback systems. Many my friend and patient also ask me to help for their maybe sexual problems, particularly in cancer patient. And then they told me that they use a Viagra or that certain common things, but they cannot perform sexual things. And the problem is that they didn't check about lutein hormone from pituitary. And also in this show, there's a thyroid hormone affecting thyroid. And the Viagra, that kind of drug, is just like a vasodilatation. But if you don't have a certain basic amount of testosterone or lutein hormone, thyroid hormone, erection is impossible. So many, okay, now the PSA is a secretory glycoprotein produced by not only prostate, but also all urinary system. So that's why if there is a inflammation in the prostate, urethritis, or any reflux, some problems to kidneys, and the PSA is rising. And also, if somebody is smoking heavily, this also rising. And the PSA function is basically related to the semen. And the PSMA is a prosthetic specific membrane antigen. This is just a prostate specific antigen. Tumors produce a lot of this kind of certain proteins, certain enzymes. This PSMA also is expressed in not only prostate tissue, but all other tissues, duodenum, kidneys, and also many other cancers besides the prostate cancer, renal, bladder, testis, colon, breast, etc., even including neuroendocrine tumors. So nothing is specific. So a urologist or a medical sort of oncologist often ask me what happened when they couldn't find any recurrence or metastasis. PSA is rising. And they have to check first any inflammatory process around the urinary system. Okay, but this also same thing. PSMA is non-specific. Many inflammatory process by blood flow phenomena and other cancers also takes up PSMA. The antibody continuously is in research to try to make a better sort of clearance or imaging purpose. Initially 617 subtype, that shows a lot of bladder activity. The recurrence after initial treatment, surgery, radiation, whatever, recurrence usually at the site of initial surgery, initial radiation. So that's around the bladder, we call prosthetic bed. And so if there's a lots of activity in the bladder, it is impossible to pick a 1-2 millimeter sized recurrence in the prosthetic bed. So this was disappointed. And then 11 was better. Now 1007 is far better, much less bladder activity. In other words, when you're trying to manipulate antibody, if lipophilic antibody, it goes to all the liver a lot more, liver, spleen. But if a hydrophilic antibody, it goes to the all urinary system. So you have to somewhat balanced by chemists. And it has been labeled with various isotope technetium, gallium-68, and F18, indium-111, and the lutetium-177, actinium-225. I will show you some examples with this labeled compound. And then axamine is a synthetic sort of a leucine amino acid. The commercial name is flucyclovine, and FACBC is chemical name, so same long name. Somehow we have used the last amino acid, including methionine, glutamine, and then also some citrate or choline, etc. But those all metabolize and make a protein synthesis. And then just like FDG transported to the tumor by transporter, and then phosphorylated by hexokinase, and stop there. That's why we are seeing phosphorylated FDG on the picture. So with that idea, there's a synthetic leucine transport by the amino acid transporter and phosphorylated and stop there. Therefore, it doesn't go through the all protein synthesis. Maybe that's the reason we see very tiny 1-2 millimeter size recurrence with this agent. So which one is better, we don't know yet. But in my personal experience, this PSMA antibody seems to be better in retroperitoneal lymph node detection. And the reason is that axamine goes through the GI system. Therefore, there is no bladder activity. So it's best for recurrence, local recurrence after surgery, after radiation with this one. But because of a normal bowel activity, it's not easy to pick a retroperitoneal recurrence or metastasis. But on the other hand, the PSMA, as I said, it goes to urinary system now with this one less. And so retroperitoneal metastasis seems to show better with this PSMA. And certainly bone metastasis also better with the PSMA, not axamine. But there's not enough data. Only few papers from UCLA comparing these two agents in limited things. And so we don't know, but to me, this is very helpful for recurrence. And this one is most likely useful for the therapy using lutetium-177, same PSMA antibody. Because this one has not been labeled with this kind of theranostic agent and then tested yet, but somebody will be. Now, yeah, I think so. Okay, now, what is the function of prostate? Prostate makes some fluid to make a semen. Okay, semen is also produced, produced in seminal vesicles here, seminal vesicles. Now, the sperm is produced by the testicle and transport through vas deferens and come here, mix with this fluid from semen and prostate, and by this sort of ejaculatory ductal system surrounding muscles together, ejaculating. At least 78% this fluid that's called semen mixed with this fluid from prostate and the sperm together is ejaculated. And so this is the anatomical structure. Okay, you can see on this old diagram, okay, this peripheral zone is certainly in the periphery, in this pink back here, and then this center is central zone green, anterior, the anterior superior, anterior is blue, anterior superior, this is transitional zone. The 20% tumors are here, 10% tumors here, and 70% tumors here. Okay, so in the transaxial imaging we are often using for diagnosis on ultrasound, MR, you have to look at it, but the shape is very variable individually. Older people have very thin peripheral zone. Younger people become very thick peripheral zone. These two cannot be separated on the images. And there's a lot nodular appearance here because of hypertrophy, hyperplasia in any patient over 60. Okay? But at least you can see this okay, pink, that's peripheral zone, and central zones are more posterior, and the transitional zone is the anterior superior. Okay, on this axial or see peripheral zone here, the ultrasound also resolution is getting better. So this is a quite old slide, but the transitional zone is anterior here. This is ejaculatory promontory here, little nodular things here, right? That's a landmark. Okay, so when the PSA level is abnormally higher than normal range, then we start with certainly it's a conventional imaging ultrasound is usually done. If ultrasound show nodules, then often CT/MR to look at a sort of adjacent environment or metastasis. And certainly a biopsy usually done. Once you have a biopsy, there's always a hemorrhage that will disturb. It's not easy to interpret the MRI with the bleeding things. Okay. And then we'll talk about more sort of imaging aspect with this or radiopharmaceuticals. Now this, you can see peripheral zone has some echogenicity, but in cancer is a sort of decreased echogenicity. So ultrasound is cheaper, easier things, and the biopsy guiding easier, but it's totally subjective. Individual experience makes a difference in diagnosis. Mm-hmm. And the sensitivity was this kind of wide range because of that individual variation. And but the specificity It's also in quite a wide range. And you can see also involvement in seminal vesicles. That's the right adjacent organ, so it's quite often this spread, and that has diagnosis accuracy is also quite range. Now here, okay, on MRI anatomy, you can see MRI has a much better idea of the soft tissue, signals, and the anatomy is well delineated. Okay, and then particularly the seminal vesicle on T2-weighted images show a lot of this vesicle fluid collection. So if the tumor involved, you will see a less or decreased signal. So these kind of follicles or vesicles will be displaced and things. So it's easy. And on T2, peripheral joint show high signal like this. So if there's a tumor nodular, it will show decreased signal intensity as a nodule. And the central gland show all the heterogeneous signal intensity on echogenicity. As I said again, so lots of normal hyperplasia, hypertrophy with aging. But tumors can also arise inside either central or transitional, more transitional. You cannot separate on imaging. So here again, this is T2-weighted, okay, axial, bladder, so that's good. And peripheral joint in young men is thick and this kind of things. There's no nodular, so low signal or decreased signal. It's transitional, so here it's all the nodular heterogeneous. Okay, this kind of. And so here, example, the tumor show nodular decrease, slight heterogeneity, but here is always heterogeneity. This could be tumor, this could be tumor, you can't tell. Okay, so this is a peripheral joint, sure, that's a tumor. So easy to have a biopsy. So you can see here, prostate upper is called base. Down is a cone shape. Down is the apex. Middle is the middle gland, mid gland. So the shape is different. Like a peripheral joint versus okay, on MRI, as I mentioned, low signal intensity nodular lesion. MRI is important to detect extracapsular. The prostatic gland has a capsule, is outlined by very thin, low signal intensity rim. If that rim is not clear, and then you suspect some capsular penetration. This makes a difference in staging, I will tell you more. And then certainly seminal vesicle invasion is easy on MRI. And we also use gadolinium DTPA, sort of a dynamic study as usual for all cancer study to see any contrast enhancement. Tumors has a neovascularity, so any aggressive cellular proliferation show contrast enhancement. So there's a busy slide, but all the parameters you don't need to, but it's a very standardized routine. T2, T1, and contrast, and we are now using also diffusion imaging. Diffusion imaging is similar to our the FDG scan. So if there's a very solid tumor, the macromolecules are not moving around. So there's a restriction of water molecules. That's what this diffusion imaging show. But as I say, only very aggressive tumors And then the small tumor is not easy because the resolution is not sharp enough to pick a small lesion. But sometimes it's very helpful in separating inflammatory nodule versus neoplastic nodule. Okay, here's the old slide, but shows some nodular signals here in the peripheral left posterior lateral, but the tumor was in the apparently anterior, this place in the transitional zone. But central zone is also very heterogeneous. So that's why it's a difficulty sometimes. And it certainly after biopsy, subacute. So subacute means usually 10 days after that. There's a MET hemoglobin, which is a paramagnetic. So that will show high signal intensity on T1 as well as T2. So it will block, if there's a tumor, it will block this with this high signal on T1, T2 after biopsy. So biopsy makes a very limitation of MRI utility. Again, this central and transitional joint show diffuse heterogeneity. So if there's a tumor, you can't tell whether there's a tumor or not. So only many times if PSA is rising and you don't see anything here, and you see all this, and then you have to bet. So only surgery, removing things, can show some tumor cells. Okay, this again, this kind of things is this is diffusion imaging, and this is we call ADC mapping. And the signal on diffusion imaging usually show high signal on pathology like cancer, but the ADC map show low signal opposite. This is just a quantitative measurement of that water molecule. It's a less sort of restriction of water molecule. And okay, but in the paper, there was some correlation between the ADC number, quantitative number of the lesion versus this grade, histological grade of, but no one is actually using this kind of things measuring because there's a lot of artifactual thing. It's not reliable. And we also do some kind of MR spectroscopy. The choline substance, which is related to membrane potential. So any tumor proliferation will show increase in membrane potential. That will reflect choline is related to fatty metabolism. Yeah. So it will show some low signal intensity nodular lesion on T2 in the periphery left side. And then when we apply MR spectroscopy, it shows the choline. Normally choline is very low. The choline normal side is low. And so citrate is rather high normally, but this opposite. So that's another sort of a supplementary type, helpful things. And the choline has been tested, but as I mentioned earlier, this is non-specific again. Only very aggressive tumors often show some uptake, fatty metabolism increase, but no one, this is still, there are still lots of papers I see, but this is far less accurate than PSMA or Axmin labeled with F18 at this time. MR imaging also nowadays connection with this biopsy tool. So if there's a suspicious lesion, the MR needle can be inserted and have a biopsy just like any other CT ultrasound. But certainly this is more sort of equipment time is consuming. Okay, now for staging, okay, T1 is certainly localized in the peripheral zone, and then T2 is still here. As long as there's a capsule penetrate, that's T3. And then if there's a seminal vesicles invading, that's 3B. And then the bladder or surrounding bone, other thing, distant, all T4. For most cases nowadays, T1, T2, all T1, T2. T3 is even rare. In very 20, 30 years ago, we saw quite a lot about T3 extra capsule, but nowadays it's very rare to see because we diagnose patient very early stage. Okay, here you can see a capsule here, peripheral zone on MR. Even this old slide still line, but you can see the line here is disrupted and some nodular bumpy, low signal intensity nodule is here. So that's a T3, the extracapsular. So neurovascular bundle is right here. Posterior lateral, there's a neurovascular bundle here. Okay. So this is important finding. And so it's MR is best to staging 3, separating stage 2 and 3. Okay, you can see here also. This more recent, you can see this capsule here. Some here is a little disrupted, and another extending here it comes. So this is also T3. And sometimes it's not easy, but this. Okay, so that we can see ADC map in that kind of questionable case. There's a whole low signal AD in in real computer. Once you see it, will show numbers together. Okay, but the okay. The seminal vesicle environment, as I said earlier, normally on T2, seminal vesicles show high signal because of water, follicles or vesicle. But if this water is replaced by tumor, it will show like this. Okay. So in this case, okay, peripheral zone here, and the capsule penetrate and then goes to this left side, the seminal vesicle. Okay, and then certainly a bladder base environment or this rectum, rectal wall environment. Okay, all this are certainly outside the capsule thing. These are all stage 4, and obviously bone lesion, stage 4. Now here, as I said, the transitional zone is anterior superior. If there's a nodule, you can see it's a bumpy nodule, but this could be just a hypertrophic, hyperplastic macronodule. Micronodule becomes a macronodule and becomes cancer in any other organ. So we have to find out some kind of easy way to find the potential of this kind of benign nodule, like a polyp in colon, polyp. Polyp becomes adenoma, adenoma becomes cancer. So which polyp goes to that kind of continuous cellular transformation? So that's the key issue. But the biopsy, all things, is very limited. And then the real problem is biology is dynamic, continuous process. These cells are for a long time quiet, but at some point, all of a sudden become very aggressive. So that's often related to stress often relate to certain environment, often relate to certain inflammation. Inflammation is triggering things. So those things are well known now. But if we have a certain imaging technique and labeling with certain gene, potential gene, at the MD Anderson, they trying to smear the gene. Smear the gene apparently triggering a lot of aggressive proliferation. So they are biopsying and trying to find the smear gene. If smear gene is in the hypoplastic nodule, they recommend the surgery nowadays because there's a potential for cancer development. So again, PSA is normally less than 4 or 5 nanogram. Okay, and then if there's a 5, 6, you repeat because there's a slight variation between the laboratory and patient condition, smoking, other things. If there's a continuous high, then transurethral ultrasound and shows any nodule in the peripheral zone biopsy. But if there's a tumor in the central gland, oh, you cannot hit which nodule you have to hit. That's a limited. Then you have to have a MRI, MR spectroscopy, contrast enhanced MR, any other things together. Nowadays, maybe some kind of PSMA antibody or leucine, synthetic leucine amino acid. And then all together, more tests is better. So this well-differentiated cancer goes to poor differentiation. So there's a Gleason score. The pathologists look at a shape histologically, and then make a number. If this number altogether is greater than 6 or 7, then you worried about it. Okay, but certainly greater than 10, oh, there's no question that tumor is spreading out. But less 6, 7, that's a sort of a junctional point. And then either observing or some short follow-up. Short means every 3 months thing. But as I say, if you end up biopsy, then biopsy makes it more difficult to diagnose on imaging and also on histology. So that's, but this is a anatomical study also, not a functional study. Now, using machine learning, there's lots of papers. We don't need the pathologist to look at all the cell and count. Machine do all this kind of things. So it's a much more accurate now, but this is a biological phenomena looking on the slide. So it's just stationary, but this changing every hour. So it's not always accurate. So in general management, you have to wait and see if my friend got this kind of initial diagnosis at age 70, I would advise active surveillance. Okay, if the patient is a young patient, certainly radiation or surgery, there's always debate. Now, in old days, about 20% of surgical cases showed the complication. Usually, leaking urethra or inflammation, those things is gone. But major problem is that they cut the neurovascular bundle. So the sort of a sexual problem, erection is impossible. So in MD Anderson, 10 years ago, we had more lady urologists. And because they are doing microscopic surgery to save that almost invisible nerves far better than male urologists. But that's still not easy. You know, nerve is like our hairline. So there is a technique. Try to image nerve like a hairline by certain special imaging technique. And that will be helpful. That's in the research. And radiation also provide make almost same outcome, but again, radiation used to be a lot of problem, proctitis, inflammation in the rectum, that's and some burning, all this around the lower pelvis. But now, using computer technique, they focus to only just certain tumor. They improve the land. But there are three major choices in radiation therapy. Proton therapy, that's by physical principle, they're radiating only the tumor on the computer. But that's most expensive. That's usually $250,000 at MD Anderson. And then next is IMRT. That's an imaging guided sort of a linear accelerator therapy. That's about $50,000 to $100,000, much cheaper, half of the proton therapy. But the outcome is the same. Outcome is same. But in Korea also, we have two places with there's a proton therapy. And by listening only physical principle, most patients chose to have a proton therapy because they worried about sort of damage to surrounding rectum or some pelvic muscles, bones. Even though I advise them to choose only just a cheaper IMRT therapy because of the same outcome. So that's a psychological things. And that's radiation therapy is a local therapy. Okay, cancer is a systemic disease. So for local recurrence or local therapy is okay. Surgery, radiation is the same to me. So depending on the cost, you can make a decision or advice. 70–75% of cancers are hormonal cancer, as I mentioned earlier, androgen. So we have to, if there's any aggressive tumor on PSA 10 things, or if imaging show extracapsular, or patient has a recurrence, you must start with androgen deprivation therapy. Usually we use a Lupron, which makes a reverse. Okay, I never seen any prostate cancer patient with the feminine type. All muscular, very strong men usually have this prostate cancer. So after we give this therapy, they all complain because they become almost like a female. Very muscles are very weak. They don't have energy. They don't like this therapy. So there are many new drugs of sort of same sort of androgen suppression, but less side effect. Okay, and then there's also local cryotherapy. It's a freezing. There's a prostate or cancer, and then this high intensity focal ultrasound also destroyed. But that's only for visible tumor. If there's also the problem we see is that we assume that tumor is only in the nodula, the lesion on images. But actually, there's a lot of invisible tumor cells surrounding. So if you are focused, then you miss all these surrounding invisible cells. They are escaping very fast because of heat. When you use radiation or ultrasound intensity or they escape very fast. So they will go to liver or lymph node, liver, bone, etc. So laser, same thing, laser, photodynamic, all sounds good locally, sort of burning the lesion. But how much, nobody knows because it's invisible. Okay, here's a lesion. So assume this is the only tumor, but actually there were usually lots of tumors in surrounding. You can't tell. So this kind of say, okay, a special computerized technique shows highest dose here and less here, but much less surrounding. So sounds good. That's why they, oh my gosh, we need a very expensive proton therapy. But from my experience in 20 years, these patients usually have much faster metastasis because the invisible surrounding these tumors escape very fast because there's so much high burning, heating on it. But using IMRT with this technique is good enough for me. Much cheaper than proton. Okay, surgery has the most common complication is the lymphocyte because they cut lymphatic chain, and so lymphatic fluid is accumulating. But this is automatically slowly observed. But if there's a lots lymphocyte, you must have another surgery because there's a very sticky fluid. So a lot of inflammation occurs. Just like abscess. Abscess is a bacterial contamination and makes a lot of things. Certainly bleeding hematoma, this will go to abscess. And the leaking is a major problem. Or the prostate urethra is very thin. If they cut, because the prostate is right adjacent to the prostatic urethra. Prostate urethra runs inside the prostate. So when they cut, they often cut the urethra and makes a leaking. That's a major problem. They have to reoperate. So that's called, we call urinoma. Now, erectile dysfunction is certainly major concern from our patient, and even without prosthetic, people are living longer. Unlike females lose estrogen when they become menopause completely. But in male, testosterone will not disappear completely. Less with aging, but they do have until they died. So as long as we supply testosterone, they still have a sexual function. And there's a lot of psychogenic, neurogenic, endocrine, all other lesions contributing erection dysfunction. But this is actually Pfizer, for example, Pfizer chemical, the pharmaceutical company, make a Viagra. Viagra, they make a profit more than combining Korean-based Samsung, Hyundai, or LG, three company. One drug profit makes more than major some electronic and car company, all that thing. See, unbelievable. So because lots of males living longer, they want to have a continuous some sexual function. And so that's the reason. Now, there's lots of causes. The major cause certainly vascular, because of diabetes, other things together. All the vascular problem is or aging problem, and many other neurogenic other things. So now there's sort of a plastic urology surgeon opened up this dorsal artery, penile dorsal artery. See, this is one of dominant, this penile artery here, but this side doesn't have, there's some tiny collateral things. When this block anything, blocked by either thrombus, emboli, or by extrinsic compression, or a lot of causes. But this one, when then penile function will be certainly dropped down. And this is a common lymphocyst we see on T2. It's a fluid along the pelvic wall. So lymphatics here, they cut things. And certainly, this is all fluid show high signal intensity on T2. So on MR, this axial or sagittal, it's easy, bladder and some fluid is going out. That's leaking, all this leaking. And the recurrence, as I said, is common in 30 to 50% after initial surgery things, and usually right around initial site, that's usually prostatic bed, just below the bladder, neck. And then certainly there's a recurrence, then you go to node, lymph node, first pelvic lymph node and retroperitoneal, and then go to the liver. And then once they go outside, they go to lung, and then bone. That's usually metastatic sequence. So it's a recurrence usually right in the area here, but it's right, this bladder, right? And so MR, but this is a big one. But if there's tiny one right adjacent to the, attached to the bladder wall, it's not easy. Because all high signal put together, it's not easy. Yeah, okay. If the prosthetic capsule is penetrated, then obviously the tumor goes to the usually external iliac lymph node. But we have seen prostate cancer metastasis to the inguinal lymph node, as well as presacral or we call perirectal sort of lymph node. That's an unusual chain. Usually external iliac and then common iliac, and then go to para-aortic lymph. That's a usual. But in rare cases, we see go down inguinal as well as way back around the rectum. That's a well reported. Is there some question? There was some noisy. Oops. Okay, here's a lymph node. Okay, here's a inguinal, some femoral here. Inguinal has a superficial and deep, and external has a three, usually medial, lateral, and obturator. And then this is the internal. See, this is all based on arterial system. Okay, this is a aorta, common ilia, and the external ilia, internal ilia. So the lymph node here is an internal ilia lymph node. That's a hypogastric lymph node, another name, same thing. So common is right here, the external ilia. External ilia has a medial, lateral, and obturator. Obturator is sometimes confusing with the hypogastric, but you have to know how to separate inguinal from external ilia. Okay. On CT, there is a vessel, inferior hypogastric artery is separating this. On nuclear imaging, you cannot separate because you don't see that vessel. So MR is also difficult, but the CT, thin section CT, you can see the vessel very well in separating this inguinal from external ilia. Okay, I may have a slide, I don't know. Okay, this is a lymph node, okay, and it's, since if we have a contrast CT, then you outline usually artery, vein, lymph node. And then this kind of is vascular sort of line. Okay, this could be obturator or internal ilia. So you have to look at a series up and down to connect or some reconstitute coronal. Coronal will be easy to see the all chains. So, but you can see nodula, and then lymph node often show a little bit low or intermediate signal on T1 and a little bit high signal on T2. Okay, that's it. And here you can see bumpy. This is a lower sort of lateral external ilia, and then CT often show vessel. So is go up and down the inferior hypogastric artery. You have to look at it, and then this upper, this is L2, 3 level here. It's a bumpy here. It's aorta is a left para-aortic, some lymph node left, and so on. Nowadays, all this is a retroperitoneal, but when you see, you have to describe. There is a nodular para-aortic at the level of a kidney, something like that. So the clinician can figure it out, oh, where are all those things? Rather than just, oh, there's a lymph node in the abdomen or retroperitoneum, that's a huge space. Okay, here is a coronal. So it is a lymph node, intermediate signal on T2. This bladder is a wide as T2 here. Okay, there's a small here, small here. Okay, there's external ilia, external ilia. So here is an unusual case, pre-sacral here. Sacrum is a pre-sacral. Way down, it could be here, is a lower, pre-coccygeal, it's coccyx, or perirectal lymph node. But that's unusual. So now, okay, prostate cancer in 85% goes to bone, just like breast cancer. Breast cancer also go to the bone. So I'll talk to you why. The common site, all bone. Every bone goes there. Every bone. And but unlike others, prostate cancer is often osteoblastic. That's at least 70–80% blastic. So that means on CT it's a white. But the other cancers mostly osteolytic. That means a black on CT because destruction. Lytic means osteoclastic activity is destroying matrix, bone matrix. So it shows no healing, but osteoblastic is a healing. Our bone is always remodeling. Our normal bone has a balance, osteoblastic and osteoclastic. If osteoblastic is a predominant, you'll see a growth of bone, like a degenerative spurs or kind of. But if there's a lung cancer or multiple myeloma, destruction of bone, you lose matrix, you'll have a pathological fracture or and sort of a certain moth-eaten appearance, that kind of thing. Okay, so why? Because this means it's a slow growing. Prostate cancer is a slow growing. And also blastocyst. So we are using MDP or fluorine. It goes to only osteoblastic. Okay, in nuclear medicine, we don't have any agent to go to osteolytic metastasis. That's the major problem. So our chemists should consider developing some agent to show osteolytic lesion. That's a far more common and far more problem in clinical practice. And in the MD Anderson, they developed a peptide they call N-telepeptide. We now measure from blood test. It's produced by osteolytic metastasis. So if we labeled N-telepeptide, it will go to only osteolytic lesion. That would be very, very helpful in diagnosis and evaluation of a therapeutic response. Now, some region, prostate cancer goes to a lot more bone, but somehow they don't produce pain. Okay, pain correlation is about 40%. Some patient has a pain, but much dull pain. In bad cancer, like lung cancer, breast cancer, if they have one metastasis, they have mostly 70–80% exclusive pain. But in prostate cancer, even though they may have metastasis whole bone, they don't have pain. Why? Nobody knows. Still, pain mechanism is totally unclear at this time. So that's why when we trying to treat prostate cancer patient with bone metastasis, it is still difficult to evaluate patient because they don't have pain. So I use only alkaline phosphatase. Alkaline phosphatase often relate to osteoblastic metastasis. So if the alkaline phosphatase in the blood was high but reducing after treatment, that seems to be responding. But MD Anderson, we have other certain imaging technique, other things altogether. But for blood test and telepeptide for osteolytic metastasis, that's very helpful. So bone metastasis also, we are diagnosing not 100%, around 80%. So we missed all small things. So imaging technique is not accurate. Now for bone lesion, we are talking about cortical region, cortical. Okay, most solid tumor goes to cortex, bony cortex, but most hematological cancer cells goes to bone marrow, bone marrow. So until that bone marrow metastasis become proliferating and then irritating endosteal portion of cortex, nuclear medicine bone scan will never show abnormality. Okay. On the other hand, MR, which has about 80% fat in bone marrow or in adult, if there's any tiny metastasis in the bone marrow, that high signal intensity fat on T1 will show black dot. So it's easy to detect bone marrow lesion on MRI. But MRI cannot detect a cortical metastasis because there's no mobile proton in cortex. So there is no signal changes in the cortex. So MR is much more sensitive to detect a bone marrow lesion, but it's too sensitive to differentiate from red marrow regeneration, red marrow. See, our body is continuously making new red cell, white cell, platelet, etc. So if there's a anemia, then the bone marrow is trying to make more hematopoietic cells. That will show on MRI, just like a leukemia, lymphoma, or myeloma metastasis. You cannot separate. They all look like the same. So this methylene diphosphonate show osteoblastic in cortical metastasis only. So again, therefore, its only accuracy is only 80%. You cannot think about 100% because this one is only exchanged with hydroxyapatite crystal by bone adsorption, not absorption, adsorption. Exact mechanism still unclear. The F18 sodium fluoride directly exchanged with hydroxy, the OH -1 anion in the cortex. But this one, this is a +3 or 4 or 5. Technetium chemistry is still unclear. So there is no +3, 4, 5 cation in bony cortex. So why this attached to the bone, nobody knows. But we assume that's a chemical attachment. So here, okay, bones can show, this is what we are seeing is not tumor. This is all reaction around the tumor. If tumor cell go, there's a reparative process. That's osteoblast formation. That's what we are seeing. If it's so much this kind of increased activity, there's not much excreting through the kidneys or bladder. This is called super scan. Okay, every bone, but no pain. That's the usual. Why? Nobody knows. Okay, here, okay, prostate cancer, they show a little bit here, up. Okay, and there's some in the spine, usually pelvic bone, and the spine is the most, because this we call axial skeleton. Pelvic bone, spine, and anterior, posterior ribs, that's it. That's because 80% of red metals are here. So hematogenous metastasis goes to here. very 3% red matter in the cervical spine. So if there's something that's mostly degenerative change, unless there's a widespread like this. And then this kind of things, it's all just needs, that's degenerative changes rather than metastasis. Somehow, well, the synovial membrane is protecting for cancer invasion. So it's a rare environment of metastasis in the joint area by cancer. So this is a continuous series on one patient, and androgen therapy. Okay, there's not much response still there, but some maybe same or better. Now, this is a sort of a vaccination, sort of using antibody, even well, it looks worse, and therefore they get chemotherapy, Taxol here, worse. And the enzalutamide, that's another new sort of androgen suppression. And it's not much helpful, it's a continuous. So some responding, some. Once a tumor goes through all this progressive thing, it's usually difficult to control. And bones can show nicely all progression. Okay, now this sodium fluoride here, MDP compare, it look alike, but because of a better resolution by PET camera, it looks like a much sharper, and certainly maybe detect a little tiny lesion better. But new, cadmium zinc telluride new SPECT system has even better resolution than PET, so it will show. But to me, it's about same, and also mechanism is totally different, as I said. Phosphate is a chemical attachment. F18 is a direct exchange with hydroxy anion in cortex. So you can, if you want to try to compare, that's nonsense. It's totally different too. Okay, but to me, it's about same. Now, okay, so advantage of nuclear bone scan is the whole body system, whole body, looking whole thing, and spine again. Pelvic axial skeleton is most common here. Now this is a trochanteric area, and this is a maybe glenoid portion of scapula. But when you have a lots of this, there's no point to have a SPECT. But if there's a single lesion or a single one, it's better to have a SPECT to localize precisely location. And second, the characterization of the lesion better with the combined CT. And then certainly with the three-dimensional display of SPECT CT, you can have much more accurate localization and characterization. So it's trying to make a less false positive or false negative. Now, in the past, certainly the sharp resolution, and they trying to, outline and quantify the tumor volume things. Okay, but in prostate cancer, this may not be necessary because usually clinicians go by PSA or PSMA level, and treatment would not be really changed with this volume changes. Now, as you know, there are two radiopharmaceuticals, two treat the bone pain as well as a bone lesion. Strontium 89, this strontium is a +2 cation, so that directly exchanges the calcium in the bony cortex. So there's an increased activity here, and after you give strontium 89, almost it's a Bramstrong sort of here's a compression things here. When you see horizontally increase, that could be benign compression or malignant compression. So on nuclear medicine scan, you cannot separate. But MRI can show, or CT shows compression, and the pathological fracture usually show very irregular margin and destruction. Compression, traumatic compression is just smooth, just a compression. So the margins are usually maintained just a straight line, but the cancers are usually very irregular and the osteolytic portion. So spexity or opacity can characterize that abnormality and make a more accurate differential diagnosis. In this one, you can tell whether this is a benign or malignant. Now, samarium, now on the other, this strontium 89 is a beta rate, very high, 1.46. So you cannot make a good picture. This is a Bramstrong sort of a picture. But this is samarium 153 EDTMP, that's a phosphate. It goes to the osteoblastic lesion. And this one has not only beta, but also gamma. So that's why we can take a picture. So it looks like an MDP picture, similar picture. So that's the advantage. It's just showing osteoblastic lesions and then a response if we have a serial scans. But because of this gamma ray, you have to admit the patient and then protect others for radiation. Okay, nowadays, rhenium-223 is the most popular, although this is most expensive. This is alpha energy. So it's a limit. So it hits only just tumor cells. So we don't have to worry about the radiation protection. And the it's again hit the calcium hydroxyapatite. This osteoblastic metastasis. So this will be most probably efficient, but the cost is a problem. And it's radium-223 has been also used, but the same. This alpha emitting theranostics become a hot topic, and then it break DNA double, so more efficient, alpha, more efficient. And so you'll hear, okay? And then, so it's a certain advantage. So you'll be here. So again, by serial imaging, so you see the less sort of reaction with the improvement. Now, PSMA, as I mentioned earlier, seems to show a lot better on bone, active bony lesions. This is, you are seeing tumors. This MDP, you are seeing reactions surrounding tumor cells. But the PSMA has a limitation. About 15% of prostate cancer do not produce PSMA. So in those patients, PSMA test is useless. So you must analyze tissues to find out PSMA first before you do PSMA imaging and therapy. So PSMA is a diagnosis, and the radium-223 therapy seems good combination. Now here, okay, the bones can show some lesion, but this PSMA PET show a lot more here. Okay, now the molecular imaging, but nuclear medicine imaging is basically molecular imaging. And then certainly we certainly look at structures, but we are basically evaluating biology of disease process. And in prostate, you can see a majority is adenocarcinoma, but there are also small cell behave like a neuroendocrine tumors here. So it's a combination group or something. So this small cell type and neuroendocrine prostatic cancer can be evaluated by gadolinium labeled somatostatin receptor, dotatate, that kind of thing, as a chelating agent. So now, yeah, I will give you probably a talk in 3 weeks or so. That's neuroendocrine tumor in general, and which is increasing worldwide, and also every cancer has a small cell type. So neuroendocrine tumor or the type of tumor can be now assessed with our somatostatin receptor agent. Okay, now for prostate cancer evaluation, we have tested so many radiopharmaceuticals in the last 30, 40 years. Okay, FDG, which is the most commonly used for cancer, and is based on glucose transporter. There are about 5 glucose transporter, and transporter 1 apparently is influencing cellular proliferation. Once this transport of FTG to the cell, then it's phosphorylated by hexokinase 2. There are also 5 hexokinases, but hexokinase 2 is mainly important in cancer. So once it's phosphorylated, it stops. So that's what. And now the choline, again, is related to sort of a membrane potential difference. It's fatty acid, same as acetate. So, but these agents have been almost abandoned. It's not much better than the current 2 agents. Methionine also, amino acid methionine, has not been successful. Now this FACBC or axamine leucine, synthetic leucine, it become very successful as a PSMA. PSMA based on a specific membrane antigen here, but only 85%, 15% do not produce PSMA. But this one, all they transported by amino acid and then phosphorate and then stop. So these are all, every case of shooting. Now this more on this the thymidine or uracil is more sort of a nucleic acid type. Theoretically, this is a more specific or better in evaluation of tumor proliferation, but this labeled this one seems to show much less sort of activity signals. So only large lesion or very, very active lesion show positive finding. It's not better than even FTG, although this is more specific. Now the last one is testosterone, directly labeled testosterone. And this sounds like a much more specific, but again, signals is less, and maybe androgen spread the other tissues, but they're still useful for evaluation of a specific hormone therapy. So there's all, as I mentioned. The FDA approved this only two PSMA this, no others. Now this one, PYL, that's targeting PSMA. This one is not approved, but recently approved, this one. Just within a matter of 1 month, this approved. So this will be also another useful agent. Okay, show you. Now this PSMA, you can see lots of blood activity. This probably 617. Okay, it's not 1007 or 11. It's this one, but there's lots of activity in the kidney, so it goes here. This dotatate or tate neuroendocrine, also lots of activity in the spleen and kidneys, bladder. FTG, is gray matter and myocardium, and then again, this also shows lots of, but excreting bladder things, but for prostate cancer, this is useless. Yeah, okay, so there's liver metastasis. So here, PSMA, and this maybe small cell type is shown here. FTG also shows some here, but as I said, this is already maybe poorly differentiated, not well differentiated. So when the tumors are continuously changing biologically, when they reach the liver, it's already poorly differentiated, then it's sure. But it's too late for helping patients. Okay, now there's certainly discordant PSMA FTG. FTG only aggressive tumor show here, very. This time PSMA doesn't show much, although some here. But here, that's a very understandable because of different biology, PSMA versus FTG. Again, now it's a PSMA 11 is the next third. It shows still lots. This DCF PYL. This is also similar, but to PSMA. This is targeting same PSMA. So lots of blood activity is a problem for detecting early recurrence right around the bladder. This PSMA, this lady subtype, one is the best, much less, but still there. So recurrence around here is shown here, but this also has a lot of intestinal activity. So as I said, if they try to make more hydrophobic, it goes to more lipophilic and makes a lot of hepatobiliary system excretion. That's a dilemma. So PSMA, again, prostate-specific membrane antigen, highly expressed, but the other many tissues, also cancers show expression. So it's a compound, is 617, 11, INT things, but 1007 is the latest. Okay, so we would like to have a theranostic agent using PSMA, but again, only 85% of cases, 15% prostate cancer do not produce PSMA. So this labeling things, chelating, everything. So this is our hope to make imaging and therapy. Okay, so it's a lot of studies have published using this kind of agent, and then tumor versus other things. So gallium-68 versus F18. Well, as you know, there's a generator, 68, so it's convenient in small places without cyclotron. F18 requires cyclotron. And this is a short, and then, so in the Europe, they use lots of this gallium-68 labeled the PSMA antibody. But probably the cost is probably continuous. So 68 minutes versus 110 minutes, and so this time make also some imaging time. See, FDG is utilizing after accumulation in the cancer reach to maximum at around 6-8 hours. So if you wait 6-8 hours, you cannot see anything because it has short half-life. So we are imaging at 1 hour after injection. So basically we are wasting lots of activity. So only large lesion or markedly active, physiologically active lesion may take up F18, FDG, or this antibody. So kappa 64, which has a much longer half-life, that kind of things has been tested. Again, this 1 hour, you can see it's still remarkable, all retroperitoneal and pelvic lymph node. And the, 617 versus FT, this is ridiculous, this is much more specific, show lots of things. FTG is the only very anaplastic, fully differential. So comparing this two is not sort of now this is a second line subtype. Try to show this kind of tiny, see because of 11, much less bladder activity. And then recurrence right there, just below the bladder, is right here. And so all other CT, MR with contrast will show whole thing. It's not easy to pick up. This one nice. And again, this local recurrence is a major clinical problem. So this improved 1007, that's the best show right there. There's still some blood active, but this kind of things. So depending on the timing of injection, as long as there's quite a blood activity, you have some trouble. But in this case, it's nice local recurrence. Okay, certainly in the higher up lymph node, and then this computerized imaging guided radiation therapy hit the only lesion around here, avoiding radiation to basically small bowel is a very radio sensitive. So radiation therapy is always worried about small bowel radiation. So this computer technique can do by using this kind of functional imaging and then make an ideal port of radiation therapy. Yeah, so this case show lots of metastasis, distant metastasis. Yeah. So see here, so nice. They might show lesion, but what it is, you can't tell. There's something there, but they show very specific nodular PSMA antibody. There is antigen here, so it's a prostate cancer or other cancer. And then again, but in this case also non-specific thyroid adenoma. As I say, PSMA also is produced many different tissues as well as the cancers. So you cannot jump to, oh, this is a prostate cancer metastasis to the thyroid. That's you know, you have to understand the biology. That's a very, very almost reportable. It's a prostate cancer metastasis to the soft tissue, including thyroid, is a very, very rare. So and then the retroperitoneal and the liver, and the lung, and then go to the bone, and then go to some more. So the lung seems to be filter of every cancer. So if the lung doesn't show anything, or you see something else, you have to raise a question rather than just jumping to conclusion of metastasis. Okay, now these are all non-specific PSMA go to, okay, this is a right side. You see here, teeth, so it's a nose, so it's a mouth. So oral is a pharynx. So right side, oral pharyngeal, we call space. It's called space. Yeah, and then in the neck, head and neck, you have to know about the levels of lymph node. Level 1 is submental, level 2A is around the carotid body here. Level 2 is inside the sternocleidomastoid, mastoid, above, below hyoid, and above cricoid cartilage. So when you report, if you say, oh, there's an increased activity in the right neck, oh, that's a bad report. You have to precise the level, location, and the description. So you need a certain PET-CT or SPECT-CT to localize precise. Okay, now again, you notice very thin peripheral zone. Central gland is markedly enlarged and heterogeneous because hypertrophy, all things. But this is a low signal intensity on MRT2, and that shows here, abnormality here. This is a tumor on the peripheral left posterior peripheral zone. And the ADC map shows decreased signal. But the diffusion rate should show white. Contrast enhanced here. So all together. And when there's a PSA high biochemical, and this is a high up sort of common iliac chain lymph node. And this internal iliac, and then here internal iliac lymph node. Now with the bone, you have bone lesion here, and you have to characterize this abnormality based on CT. Is a first osteolytic versus osteoblastic. If lytic, you have a certain destruction, other things, and then what kind of tumor things like that. And then if this is osteoblastic, you have to say is a bony island or enchondroma. Common things to think about first. Metastasis usually show a little bit irregular margin, and then sort of well-defined things. So you have to characterize. Now this is certainly left, this either obturator or internal iliac right here. Now the accuracy is not that great, but there's depending on a lot of other factors influence it. Sensitivity only 44%, 9. So depending on how you collect cases, if the lymph node, the size things influence. The size is influencing, and then the PSA level. PSA is higher, you expect to see it more. So that kind of things influence. So you cannot just go by one paper because other now there's also lots of false negative. If there's a tiny and very lower level of PSA, less than 3 millimeter, but we do see lots of 2-3 millimeter lesions by PSMA or X-Men scan these days. And then in old days, brain, liver metastasis was missed the most of cases. But now with the SPECT system, SPECT, CT, PET-CT, it's rare to miss brain, liver change. And then certainly urinary activity masks some tiny lesions. And then again, in this 10%, 15% do not express PSMA in prostate cancer. And then certainly neuroendocrine type tumor, that's a slow growing tumor. And so, and also very small, multiple small, that's the characteristic of neuroendocrine tumor. And this is a leucine, synthetic leucine. As I mentioned, it goes to a cancer by transporter, amino acid, and then phosphorylated, and then stop there. No more metabolic process to make a protein. It doesn't make a protein in this. It's FACBC or axin. But again, there's no blood activity, so it's a local recurrence. It's so easy right there. This is bladder, right behind the bladder. And there's last case right behind the bladder on this black and white color. And this intensity is depending on size and then functional activity. That's related often PSA level. See right here. So this is a small lesion, bladder, right adjacent. This is a rectum, distant the rectum right there. So nothing else. So it's easy to pick up by this scan. Again, it's a common iliac lymph node. Medial, lateral is 2 types. So you can see here, right side. And here, left side up 2. And then here, right side, you can see. So one view is no view. If you see something on corona, you must look at a correlate lesion on axial or sagittal. Okay, this is a high up retroperitoneal. Some liver here, kidneys, muscles here, there's some bowel activity here, but this is abnormal. Okay, here, okay, there's a report of PSMA versus Axman scan, and they claim PSA is better, but to me, in my experience, it's there, but depending on the timing of things, it's about same. But the advantage of X-Men is to detect local recurrence without blood activity. Here, blood activity, so local recurrence around the bladder is not easy. It's all recurrence. Okay, again, this kind of things is right side posterior lateral peripheral joint here, slightly increased. It's not easy, but a little bit. Now, in this case, there's a bony lesion with X-Men right here. And then the CT didn't show. MR may show because this is a marrow environment, not the cortex environment. You'll have osteoblastic reaction. But there's no osteoblast or osteoclast in the bone marrow. But in the cortex, there's osteoblast, osteoclast. So if there's any even stress, pounding, trauma, any infection, tumor, there's a quick osteoblastic accumulation for healing process. That's our body response. That's what we are seeing on MDP scan, phosphate scan. Now, it's this X-Men, you can separate the prostate from non-prostatic tumor. Here is a breast. Well, the X-Men is also non-specific. This amino acid, leucine amino acid. So now but it shows this kind of breast cancer as well. Now, small molecule has been developed to inhibit this adenosine receptor. You know, we use adenosine for stimulating myocardial, the vessel, and there are 3 receptors. This A2A receptor stimulating, and that's usually increased cellular proliferation. So this DC5 FPYR, whatever that is, this long chemistry name, that is sort of inhibit antagonist of this adenosine. Okay, so to make immune cells, because this adenosine, this one is a suppressed immune system. So this one is a reverse immune system. So that's the idea to label and then use for cancer. So in the literature, I don't have a personal experience, but they just, the FDA in the United States recently approved this one. And it's the targeting is a PSMA, so it's very similar to PSMA, already approved and used. So I doubt this will become survived. Again, a lot of other lesions show up. So is this prostate cancer? I don't think we can tell, because this PSMA is also non-specific and shows a lot of other cancers. And so you have to look at clinical history, clinical sort of blood test, and also other imagings. So biochemical recurrence is very common. You have to exercise all kind of available tests to, but many times it's not easy to find the reason of biochemical recurrence or rising of PSA level. And this non-specific, this adenosine antagonist also show a certain sympathetic trunk nerve in the neck this is not the tumor, okay? This is a nerve. So this everything in nuclear medicine is not specific. So you have to correlating with the clinical. Otherwise, just looking pictures, say, oh, there's tumor, that's all mistake, all mistake. You have to know the patient. You have to correlating with the laboratory finding, imaging finding, all together. This all the nerve tissue show this kind of uptake of this adenosine receptor antagonist. And the PSA may also show a lot of neck, lymph node things, and this ganglion nerves. Okay, and now there has been other sort of technician labeled whatever these things, and then compared to PSMA, and then Indian PSMA INT is a very comparable to gallium-67 thing. So, you know, as we know, gallium has been primary isotope, particularly using a generator, and then for PET CT to save money. But if we have a similar finding using indium or technetium, this will be the winner because we now have a better spectroscopy camera. So this is a better spectroscopy, all things make a higher sensitivity. So less imaging time, but advantage of spectroscopy is a longer half-life isotope. So we can imaging multiple time point imaging. As I say, tumor biology takes a long time, and one-shot imaging cannot tell whole dynamic sequence of biology. So spectroscopy has an advantage to do at least twice time point to separate tumor from non-neoplastic, like inflammation or other vascular lesions. Okay, this is a technician labeled the PSA. All show beautiful, all things. So if I see all these things, why we need expensive PET-CT? These are all, but the you know, these are all developed in small companies, but they cannot go through FDA because of the stupid FDA people ask them to have a phase 1, 2, 3, 4 study. They don't have enough money, but then when they label it, they use less than 100 microgram of this drug and using technetium. So safety issue is beyond the question. It's not completely, but we have lots of other risk factor like a smoking, driving thing. So considering safety is no question. Then efficacy should be tested in many sort of a tests. So the FDA should allow this kind of agent fast for the patient benefit. But they always ask, what is the efficacy? You know, without study, you can't tell. So that's the problem of FDA in every place. So unfortunately, these are all good compounds I see in the literature, but they published and gone, published and gone. We like to have this kind of things. You can see recurrence so beautifully here, nothing here, but nothing else. So it's just like why we use expensive PET if this is a good agent. So now finally, bone, again, as I mentioned, bone lesion is very unique in prostate and breast hormonal cancers. Okay, and certain chemokine, okay, particularly CXCR4, these are all new genes, or this chemokine, you know, there's 12 also, and then other some kind of a growth factor and the vascular factor. Too many factors are involved, so no one knows. And in osteolytic lesion, there's a rank ligand. These are this gene makes this osteoclast proliferation. And so if we label this kind of ligand, then imaging only osteolytic lesion, that will be very useful in clinical practice. And certainly for the therapy as well. So we always have to think of a theranostic agent based on this principle of biology. So once they recognize ligand or certain protein or whatever, then label lutetium, rhenium, and then try to make imaging and therapy together. So here is all published things. There's also blastic phenomena, the rank things here also involved, but many other factors. So there's too many growth factors, many things have been recognized when all these genes. But little lesion is a major clinical, because this blastic lesion, they don't break bone and no pain. So it's not big deal in clinical practice. But osteolytic, that's breaking bone and pain, all the things. So we have to, work on this kind. But rank, this is a major enzyme. So our basic scientists should look at this kind of factors, genes, try to work on this osteolytic lesion for diagnosis as well as therapy. So here, all this tiny, all this lymph node around things. And then the bone in the, unusual, this sacrum, but it's all, hematogenous to the, so there's a bone here also in the symphysis pubis on the right side. It's an unusual place, but it's occurred nearby. Okay, certainly you can see, okay, some low signal intensity, and the margin is sort of irregular, ragged. And traumatic lesion or things, it collapsed, but this margins are maintained. And here, vaguely outlined, sort of a low density on CT things, even contrast doesn't delineate well, but this. And as I said earlier, MRI, so since this kind of small nodular low signal on T1, you can tell whether this is a red cell hyperplasia or just metastasis. It's hard to tell. MDP scan doesn't show any reaction. Here's a small reaction of metastasis here, but after probably Ruperon therapy is gone. But so retrospectively, these lesions were indeed metastasis because you don't see that here. Now here, okay, sodium fluoride scan show lots of bony lesions, and then gallium PSMA antibody show similar lesion, but in this case, probably less. But after they give a lot worse, right after any therapy, we expect inflammatory reaction. So every scan looks worse, but that's a reaction. So you have to make sure about enough timing to avoid this false so-called flare phenomena things. But it's a lot worse, continued progression of worse. This is a original 617 show. That's we call iliac tuberosity. This is a iliac wing or ella, but from here to there it's called tuberosity, iliac tuberosity. You have L5, this is a vertebral body marrow lesion here, right there. marrow region. If you do MDP, you may not see the marrow region. Here, all this basically similar. We don't have already, time goes so fast. Okay, so all accurate specificity, again, depending on how you collect the patient, how much, that's all dependent. Okay, so there's a little blood scan, but this was published by some, this testosterone scan, more specific to look at testosterone androgen and functioning androgen. It's all here, the overacting. So in prostate cancer, it's overacting testosterone. Why? Because now, this, as I said earlier, many males takes a lot of sexual stimulant by drug or medicine or thing. Prostate is supposed to be degenerating slowly after 60. So, but they are taking Viagra, all kind of testosterone. So prostate have to work so much, overacting, and that will make initially hypertrophy, benign tissue is growing, but later it makes a cancer. Same thing in the breast cancer. A lot of young ladies don't like to have a pregnancy, so they take all the estrogen hormone. So estrogen, all these hormones have a sort of a good side and also bad side. So everything has to be balanced in our body. That's called homeostasis. But if there's a over or under of certain hormone enzyme, then you are in trouble. So in breast cancer, it's over sort of estrogen. They are not utilizing, so it's accumulating, because the young ladies don't like have a baby. Even they have a baby, they don't do breastfeeding. They don't get married. So the hormones in the females are not utilized. It's accumulating. But these males, they are making overacting prostate by taking drug, medical, all kind of sexual stimulants. That's all problem. So this is a more specific, we can see directly how this androgen works in the bone things, okay? And same thing, if we use estrogen, we can tell how this estrogen overacting. And there's, again, acetate is amino acid, but it's incorporating fatty acid metabolism. So in very aggressive tumor metastasis, you can see here, but slow growing, benign, early, just like FTG doesn't show. But in this case, FTG doesn't show anything because they don't utilize glucose. But in this case, they utilize fatty acid for cellular growth. So that's what this means. So you cannot just compare, oh, this is a good, this is a bad. That's a mistaking. This is a biology. This tumor at this time doesn't need the glucose, but they need the fatty acid. That's all this picture shows. And this one, bone scan, MDP, is just a reaction of phosphate, reaction of osteoblastic. That's what we are. So after treatment, or you can see changes. So here, non-specific reaction remains same, but acetate gone. That means, oh, the tumor doesn't need the fatty acid anymore for their growth. That's all this picture. Okay, now in Seoul National University, we have a PET MRI. And certainly it's an expensive tool, but uniquely, MRI show a lot better soft tissue abnormality. And PET is certainly functional. So put together, will make a ideal information of soft tissue abnormality. So prostate, pelvis, all the soft tissue abnormality. Metastasis to the all lymphatic chain and liver, lung, all things. Opacity is ideal. So local recurrence, opacity is certainly very, very useful, and certainly marrow metastasis opacity is a choice. Okay, this and again, all this PSMA non-specific things. So this must be a recurrent tumor, but this it is a metastasis lung or other lesion, I can tell. Just looking this one, it's hard to tell because non-specificity. Okay, all lutetium 170, rhenium 223, actinium 225. So this is the sort of a better agent by physical principle. But this one has advantage of imaging and treatment. So this is what we like to utilize in clinical practice. So all this, okay. Okay, the tumor burden can be now imaged in three-dimensional ways, all things, so that, maybe radiation therapists can make a different dosages of treatment based on the volume. But overall, once we have this one, the patient needs either hormonal systemic therapy or chemotherapy. So to me, we cannot give higher dose of toxic drug, then patient will be died. So you cannot do that. So it's nice to see how much volume, but it doesn't actually make a difference in patient management. But when you have a small, one single tumor, then maybe useful. But in this kind of multiple things, it doesn't make sense. Okay. So this again, before and after therapy, we see this kind of bone lesion and then lymph node lesions, and then you see the response. So there's dramatic changes with the rotation therapy. This kind of the PSA dropped down below, so that's nice. And also the serial imaging with lutetium. This imaging is a little blurred, but still enough to show response. And this, this kind of PSMA lutetium didn't show any helpful things initially, so they use actinium. It works much better. Now, certainly, physical principle, this one is much higher alpha emitting, so it's hitting only tumor things. This one is a beta and gamma, but without knowing timing, you cannot just blame this is bad, because radiation effect is sort of accumulating. So this good response is already from the here, it is accumulated slow. So it's so nice to blame this one, but you can tell without knowing timing things. But already, the reason PSA level is higher after treatment is due to inflammation. As I say, any radiation therapy, internal, outside, always show radiation inflammatory changes. So because of inflammation, PSA is expected to rise. But certainly if there's more cancer, it's rising. But most likely it's radiation, internal radiation, inflammatory reaction. So it's a nice actinium. So by expense, it's a much better survivor. It's all reported, all PSA drop down. So that's So urologists or medical oncologists love to have this kind of therapy because much less side effect. Okay, comparing this and this is a new Taxol, okay, advanced metastatic prostate cancer. And the diarrhea is far more common here. All chemo makes mucosal damage. So you have diarrhea, neuropathy, and all kind of things. But this radiation, internal radiation, initial just 1 month, little drop down blood counts. And then but general symptoms are very less manageable. That's the reason. Okay, so different types are continuously working on to try to make a less side effect. This original has a nausea, zero stomach, all dry mouth, so there's much less with new type. So it's working on it. Now, in cancer nowadays, every cancer now trying to utilize immunotherapy because our body has a normal immune cell, B cell, T cell, NK cells. So cancers usually try to suppress T cell, immune cell to win their game. But so it's a stimulating T cell. There is a tumor immune cells connecting. The hooking, the bridge can be PD1 or PDL1, depending on which side they are in. And we have lots of drugs to break that side. And that works in many cancers, particularly lung cancer or other cancers. Now breast cancer also is now on trial because of less side effect, and it can be combined with the known other therapy together. So that's a future. So these are all related to cytokine, inflammatory cytokine. Immune knowledge is based on a lot of cytokine sort of factors. So this response is already, related to certain suppression of immune cells that is related to inflammation. And this, resistant to the hormone resistant therapy, cancer, they treated the radium, show also improvement, and then combined therapy. Cancer has a known heterogeneity, and then continuous biological evolution. So individual variation as well as patient variation. There's so much, and so it's changing continuously. So that one therapy cannot be curative. So you have to combine more and more therapy. But if you do more and more, then you kill patient by the toxicity. So how we ideally combine with the less toxicity, that's the goal of our research should be. So our nuclear medicine technique is best to evaluate such a sort of a physiologic, functional status of the cancer as well as patient. And by labeling all the drug, I think, oh my gosh. So there are many new hormonal drugs developed. Chemotherapy as well, immunotherapy is now also, okay. And so I don't have much time. Okay, this, okay. As I mean, actinium J591 and whatever this number, and they show much more promising, better sort of a subtype PSMA. This is a combination with the Pembro is a PD1 inhibitor. Pembro, that's a combined this kind of thing. and then things. Olaparib is mTOR inhibitor. That's another gene which is common in ovarian cancer, other bad cancer. It's combining with this. Now, so in prostate cancer, we have to still work out some way to diagnose cancer very early, even before cancer. So the adenoma become cancer. So we have to find out how this adenoma become cancer. And certain gene, as I mentioned earlier, gene plays a role. So we have to work on gene and gene product, that kind of thing. And same thing is a prediction of certain early mutation aggressive tumor based on gene that has been already known things. So the gene produce, certain protein. So we have to find out certain protein. We can label things like that. And then why some do not have cancer? Well, many factors involved besides the genes, environment, and so exercise, routine exercise. Exercise makes our body system in more homeostasis. As I said, our all diseases relate to broken balance of or any substance. So even you have a good certain gene, but if you behave badly, that homeostasis is broken. And the exercise is the best way to restore that thing. That's been well known. But obviously other foods, all this kind of omega-3, soybean, etc., many things together, exercise back then. So this kind of things has to be continuous work. And the gene, actually, heat shock protein 90 is important also. So adenosine, as I mentioned earlier, this also now so this is a drug, AGT-4635, that's antagonist adenosine, and prostate cancer works some. Certainly this NM600, that's a sort of a anti-choline substance, choline. Choline, as I mentioned, is a membrane sort of works. So in animal, they report, and then it's apparently related to infiltrating lymphocytes. So it's the immune system works. So as any drug stimulating immune system or suppressing sort of a certain cancer-related immune disturbance, then that moderation of immune system is now a whole new field of research. And there's this kind of things, certain protein, and then they work on things. So it's been already reported. And then the zirconium-89 anti, that's whatever those things, and that works all in. But the animal versus human are quite different because the environment is different, micro tumor environment. But we have to start with animal study and then limited human trial. But theoretically, this kind of a new protein, which is on the surface of tumor cells, is another way to, in this case, this particularly accumulate in the small cell component, neuroendocrine tumor. Neuroendocrine tumor prognosis in general is bad because the small cell infiltrating in the bone marrow rather than bone cortex. So it's a much more difficult disease. So this kind of systemic therapy, but all systemic therapy has a lot of side effects. So once we have this kind of known protein, we should label with theranostic agent. This is only imaging, but they have to use more, like a lutetium or whatever, radium, and to see imaging and also therapies. Okay, my time is almost up, and I hope you have some idea what we have to do related to prostate cancer. Here, you know, very famous David sculpture by Michelangelo. If you don't do anything, just eat at home, you'll be like this. Face looks similar, but this will make trouble in almost every kind of chronic disease. So be healthy, and then try to study more. Nowadays, you have a better chance to learn a lot of things online from every place in the world. So this is a good time to study more, work more. Then you'll have this kind of heaven in the future. Okay, thank you very much. If there's any question, you can send me question or ask me now.
So, is there anyone who have questions or comments?
Actually, I want to convey one question from Bangladesh. My colleague Professor Alam asks Professor Kim's comment about high-intensity focal ultrasound on the treatment of prostatic cancer, and this is one. And if I'm allowed, there is another one, like how Bangladesh can come forward to use the Technetium 99 labeled PSMA for imaging. Professor's kind comment on that, please.
Well, okay. You probably know that where we use high-intensity ultrasound for melting small, less than 3 centimeter liver tumor, either hepatoma or metastasis, if they are in the periphery. Okay. So if there is some contraindication of surgery, that was good, but just the burning of the only visible nodule is not completely cure or safe. And so because invisible tumor cells are always around, we call penumbra area, or just around the tumor. In the liver, that has been still using, but in the prostate, it's so small. Burning of that area is not probably technically easy, and also it's better to just take out rather than burning small portion without knowing how much they have to burn. So there was this is technique still available, but practically very few places use this technique. And then second question about technetium labeled, well, I hope some people should continuously work on this stable technetium labeled anti-PSMA, sort of PSMA antibody, same antibody labeled, or hopefully labeled with lutetium theranostic agent rather than technetium for, and then tested on the imaging and therapy. But the problem is FDA. And if Bangladesh doesn't have that kind of strict rule, and convincing some Bangladesh FDA sort of people, then chemists should learn how to label things and then try to test in limited sort of cases because it's safe, because using a small amount, microdose and technetium common isotope and then test to see whether that that is useful for diagnosis and therapeutic evaluation. Because at this time in United States and even Korea, it's not easy to go through FDA channel with that new agent. Okay, any other question? Then that technician things, maybe Asmal, you can check with our chemistry professor and see whether he can train some chemist from Bangladesh. Okay, any other question?
Would there be any other comments or questions? So if there are no questions, I think the time has been almost over. So I would like, on behalf of every participant, I would like to thank Professor Edmund Kim for his comprehensive lecture of this prostate cancer. Thank you very much.
All right, thank you, bye-bye. We'll see you next week.
Yes, thank you very much.